So, now it's 10:35. Pessoal, bom dia a todos. É um enorme prazer ter vocês aqui, né? E realmente agradecer a Inês e a Raquel por essa oportunidade de termos o professor John Clarkin. Ele trabalha principalmente no Hospital Presbiteriano de Nova York, na Weill Cornell Medical Center. Ele colabora, não é, juntamente com o Otto Kernberg, que é uma pessoa bastante conhecida no Brasil, e com o Frank Yeomans. Eles têm todo esse centro voltado para o desenvolvimento do estudo de transtornos de personalidade e de tratamentos que podem beneficiar essas pessoas, principalmente as pessoas com transtornos de personalidade borderline. Eles têm um livro que vale a pena conseguir, que é o Transference, Psychotherapy, Borderline Personality Disorder, a Clinical Guide. You can find it in Amazon. It sounds to be, it's a book from 2014. It's a very complete book. And of course, there are many articles you can get from Professor John Clarkin. You know, ele é uma pessoa que tem mais de 30 mil citações, um índice H de acima de 80 no Google Scholar. You can find all the articles they produce together. So it's a very important group worldwide in the treatment of personality disorders and the development of this focused psychotherapy and transference. I will ask Raquel and Inês to talk a little bit about him. And thank you very much, Professor Clarkin, to be with us. It's a great pleasure to have you here. And we hopefully see you next year in our department. And we can have a nice coffee, nice lunch, and hopefully nice restaurant. Inês, Raquel.
Eu começo. Bom dia a todos. É com muita satisfação que nós do AMBORDER recebemos o professor John Clarkin e agradecemos a presença dos nossos colegas de departamento, de outras instituições do Brasil e da América Latina. Sejam todos muito bem-vindos. Há 20 anos, um grupo de psicanalistas do Departamento de Psiquiatria, coordenados pela professora Julieta Ramalho, iniciou estudos e pesquisa clínica com pacientes borderline. Foi assim que, há 12 anos, surgiu o AMBORDER, Ambulatório para Transtornos de Personalidade. E nossa missão tem sido oferecer assistência em psicoterapia psicanalítica a pacientes de baixa renda, formar psiquiatras e psicólogos no nosso curso de especialização, bem como contribuir para o conhecimento das patologias da personalidade através do ensino e da pesquisa. E por falar em pesquisa, o nosso convidado de hoje, sem dúvida, é alguém que tem contribuído enormemente nesse campo. Junto com o grupo de Otto Kernberg, ex-presidente da IPA, International Psychoanalytic Association, criada por Freud, desenvolveram a psicoterapia focada na transferência. Técnica de forte influência psicanalítica, tem tido sua eficácia cientificamente comprovada para o tratamento dos transtornos de personalidade. Atualmente, entendemos a enorme importância de desenvolver e publicar evidências científicas das nossas intervenções psicodinâmicas. Dessa maneira, o campo teórico-clínico inaugurado por Freud há pouco mais de um século pode se legitimar também nas ciências médicas. A psicanálise continua não somente influenciando os pensadores da nossa cultura, mas também promovendo uma série de novas descobertas que aprimoram o cuidado em saúde mental. Para não aumentar ainda mais a nossa expectativa, vou passar a palavra agora para a nossa colega Inês Quintana, coordenadora de pesquisa do AMBORDER, que fará a apresentação do nosso ilustre convidado.
Good morning. I'll talk in English so John can understand us too. So first of all, we'd like to thank you, John, for accepting our invitation. It's a great pleasure to introduce Professor Clarkin. He's a psychologist with a PhD degree. He's co-director of the Personality Disorder Institute of New York Presbyterian Hospital, Cornell University, a clinical professor of psychology and psychiatry in Weill Cornell, research professor at the Center for Teaching and Research in Psychoanalysis at Columbia University, and a faculty member of training program of the International Psychoanalytic Association, University College of London. Dr. Clarkin research activities have focused on the phenomenology of personality disorders and treatment of patients with borderline personality disorders with Otto Kernberg and a team of experts at the Personality Disorder Institute in an effort to empirically investigate the symptom patterns, traits, and neurocognitive functioning in patients with borderline, and relate these findings to a focused treatment approach. Under his direction, a very effective treatment technique based on objective relations for borderline personality disorders, the Transference focused therapy, the TFP, has been written in treatment manual form. We met John and Andrew, his lovely wife, also a psychologist and a researcher, in 2019 in Los Angeles at the research training program promoted by the International Psychoanalytic Association. We had an intense week of training with the greatest researchers in the field to learn how to research in psychotherapy. John was our factory. He and Andrew guided, encouraged, and helped us to improve the project that we are currently developing at AMBORDER, project that is entering in its third year of data collection, following, or better, chasing 30 individuals with borderline personality structure. It has been a great experience to have Professor Clarkin as guiding us. We take this opportunity to thank Professor Sergio Andreoli, who took over our project, and our psychoanalytic mentor, Julieta Ramalho, who inspired us to continue to research. And with no more further ado, Dr. John Clarkin, thank you.
Okay. Thank you very much, Inez, and everybody. Inez, can you get my slides up, or should I?
Oh, yes. You can you, I think, won't it be better for you to pass them, or?
Let me try.
Okay.
Inez, I don't see how to get it up. Can you?
Okay.
Share for me?
I'll try. Oh, there it is.
No.
No?
Wait a minute. Let's see. I don't see how to do it. So if you can put my slides up, I'd really appreciate it.
Let me try. I think this is it. Are you seeing it? Is it right? Is it?
We are seeing a beautiful island.
Island. Flavia.
Wait a minute. I got it, I think. I think I got it.
Okay.
Is that, can you see that all right?
Yes, perfect.
Okay, very good. So I thought I would try to talk to you today briefly about TFP and where it's come. Believe it or not, we've been trying to develop this treatment for borderline patients for 40 years now. And we're very lucky to have had a team of people who worked together for a long time. And thanks for the invitation from Dr. Mari, and of course, Inez and Raquel, who presented some wonderful work in Los Angeles. And I was very touched by the way they organize their service delivery so they would not lose borderline patients in their system. It's a very important idea because borderline patients tend to disappear on us because of their poor attachment skills, among other things. So this is my group and my colleagues, led by Dr. Otto Kernberg, who, by the way, fled Nazi Austria and was raised and trained in Santiago, Chile, as you know, and then came to the United States, speaking German, Spanish, and then learning English. And so we have a group of people who are clinicians, some who are clinicians, some who are researchers, and some who do both. And research really takes a group of people because there's an awful lot of skills involved. With the time we have, I'd like to talk just about the basics of what is object relations theory and our treatment, and then emphasize some of the clinical advances that we've made, I think, and some of the research advances that we've done. It occurred to me in putting this talk together that I'm probably older than most of you. And so there's really been a scientific revolution in my lifetime. When I first started out, I can remember the dominance of strict behaviorism, that the mind was considered a black box, and the only thing you could observe was behavior. You could not observe the mind. So everything about the mind was considered mere speculation. Then became cognitive behavior. People began to accept the fact that actually cognition is a form of behavior and must be included in your thinking. And now I think with neuroscience, we've gone to a period where we're guided by the knowledge, the biological knowledge, that the emotion systems are basic across all mammal systems. Emotion systems such as seeking, fear, lust, care, panic, grief, and play. And these emotion systems can be stimulated by electrical and chemical means. And so they're the very basis of what's going to be developed as the human personality. And so that with fMRI, we can now acknowledge that human beings have minds, and that the way we emote and think guide our behavior. So the basics, what is object relations theory and treatment? First of all, I want to emphasize that I think that personality disorder is undervalued in modern psychiatry, at least in the United States. So for example, in the United States, insurance companies often don't want to pay for treatment for personality disorder. So there's a lot of motivation for psychiatry to ignore personality disorder and make sure to emphasize the symptom disorders that we have medications for. Obviously, that's important, but it's also important to recognize that 50% of patients in clinical settings have personality disorder, and about 11% in the general population. It's also true that axis 1 or symptom disorders, when they're comorbid with personality disorders, don't respond to treatment as well as those without the personality disorders. And so we think that you have to attend to the personality disorder itself. I'm sorry, I can't move my slide. There I did. Okay. So in object relations theory, a central concept is the concept of the internalized object relationship. The basic idea is that ever since you were born, your brain almost drives you to have relationships with other people. Because when you're a child, your very life depends upon the caregiver. And in the interaction with the caregiver, you are constantly internalizing a representation of yourself and a representation of the other with an affect that is connected between the two representations. And we're saying that the basic psychological structure then is this internalized object relationship. And we're saying that as that matures and grows, it really organizes your subjective experience of yourself and other people, and it organizes your behavior. So that a child may experience self as a well taken care of self in the hands of an attentive mother or caregiver with a sense of gratification of needs in this relationship with mother or the attentive other. Or there may be situations in which the infant experiences self as a neglected self with an inattentive mother and intense frustration in between. So we're saying that the origin of these internal object relationships, which we all have, are patterns with caregivers. They're internalized as memories. They are colored by wishes and needs and fear. They're colored by the level of cognitive development. And we think that there's not a one-to-one correlation with actual events, that the memory structures may be distorted by wishes and fears, and even though they're not actual representations of what goes on. I realize I'm beginning to get into a pattern of talking really fast, as people do in New York. Is it okay? Can you understand me?
Yeah, I think it's great.
Should I slow down a little
No,
bit?
Joan, you are wonderful.
It's great.
You speak like Portuguese. It's
Okay.
very clear English. Please go ahead. Very good. Thank you very much. It's been really, really great.
Okay. So here's just a graphic representation of the self with internalized experiences of self and other and related affects. And the normal person is flexible in their relations with others. They manage conflict. They have a central sense of self with a continuous sense of themselves over situations and over time. And these normal internal senses of self and others are also associated with complex affect states, with a predominance of positive affect rather than negative affect. And so there's a flexible management of conflict with other people. You can have conflict and disagreement with other people, but you continue the relationship because you have a firm positive sense of yourself and of other people. Now, this is not true of people with various levels of severity of personality dysfunction. We think due to genetic factors and environmental factors like parental neglect, abandonment, and so forth, there are distortions in the internalization of these representations of self and others. These distortions take the form of defensiveness, focused and limited, often negative perceptions of self and other people with the predominance of negative affect. And I'll talk about it in a moment, but we've used 3 different ways to try to investigate the nature of these internalized representations. We've used reflective functioning scores. We've used functional magnetic resonance studies of emotion regulation. And we've used what's called ecological momentary assessment, which is just a fancy word for using diaries to study the daily interactions of other people. I'll talk about it in a minute. So what's the objective of TFP, or our treatment approach? Our objective is to help people change these internal representations of self and others. And we think that the internal representations of self and others are exposed in the treatment setting by the way the patient relates to you, the patient's attitude toward you, the patient's perception of you, and the patient's perception of themselves at the hands of you. So, for example, our borderline patients will come in one day to a session and be very angry, and we ask, well, what's going on? And the patient says, well, I was mistreated on the bus coming here, and you mistreat me too. And we say, well, what do you mean? And you say, the patient says, well, because you really don't care about me. You just want to do your research, and you're not interested in me. You just want research data. There's no way in the world that you could be interested in me. So this is a dominant object relationship that's being exposed right in the room. And we love it. Don't get me wrong. We don't love being attacked, but we love the fact that the dominant internal relationship is being exposed. And we try not to defend ourselves. But, you know, the supportive therapist at that point would say, oh, no, you got me wrong. I really care for you, and I want to help you. That's the reason I got into psychiatry. And we don't do that. We say, well, tell me more. Where did you get this idea? We try to fully expose the internal object relationship on the way, hopefully, to transform it. So as we have done it for borderline patients, and I'll talk about later how it's changing, it's an evidence-based, manualized outpatient treatment, sessions 2 times a week for at least a year, and we combine structure. We set a treatment contract at the beginning as to what's necessary for the treatment to occur, and exploration of these internal object relationships, not only with the therapist, but how they're relating to other people in their life right now. So how has it changed? I want to focus today on how TFP has changed with our experience, with our research, and how it's changed research-wise. First of all, clinically, I want to emphasize the importance of assessment. At least in our clinics, often the borderline patients come to us in a crisis. They say, oh my God, I lost, my mother moved away, I lost my job, and I need medication. And they want to get into treatment very, very fast. And we try to slow it down, because we realize from experience that if we get involved in a treatment where we don't know all the pathology, we can become responsible for some very, excuse the word, crazy behavior. So we try to slow it down. We do a careful evaluation with careful, semi-structured and clinical interviews which Inez and Raquel have been using what we call the STIPO-R. So I'm sure they can tell you more about that structured interview. So we try to slow it down. And as the last item on this slide says, these patients lead chaotic lives. And when they come to us, even when we do an assessment, often their description of themselves and their lives is very chaotic. And so we try to make sense of it in hopes that as we try to make sense of it, they are beginning to make more sense of themselves. I'll never forget, years ago, I did the STIPO with a borderline patient who was in the hospital, but was also a nurse. So she was an educated woman, but quite sick, really. So I did the STIPO with her. And at the end, I asked her, what was your experience of going through this information? And she said, well, it was good and it was bad. And I thought, oh, well, that's a typical borderline statement, really, good and bad. So I said, what do you mean? And she said, well, it was good in that you asked me questions that nobody else has ever asked me. And I'm beginning to learn some parts of myself that I didn't quite realize. And I said, and the bad? And the bad is that I feel badly about how many questions on which I said, yes, I have that experience. But at least she felt like she was in the hands of people who knew about her situation and knew in ways that she had not experienced before. So the bottom line this morning is that there are serious flaws in DSM-4 with its 10 diagnostic categories of personality disorder. We know, for example, that you can meet 5 out of 9 criteria for borderline, and you're considered borderline. But believe me, it makes a big difference which 5 you meet and whether you have 5, 6, 7, 8, or 9. So that it's a polythetic approach, which leads to a lot of heterogeneity. Secondly, we know that practically all the patients in our treatment centers have more than one personality disorder. If they have one, the odds are they're going to have 3 or 4. So that makes us question whether there are 10 separate categories or not. And so what I'm going to show you is, as we go forward, is that both DSM-5 in its special section 3 and ICD-11, which is coming out from the World Health Organization, are beginning to de-emphasize categories like borderline and to emphasize the severity level, ratings of severity. So this person has personality disorder or not, and how severe is it? And it's interesting to me that when you do studies across large groups of personality disordered patients, and you look at the factor structure, the central big, large factor in all personality is really composed largely of criteria for borderline personality disorder. So it may well be that the heart of severe personality disorder is really what we've been calling borderline personality disorder. So that may be, and it's a lot like what Otto Kernberg has called for many, many years, borderline personality organization, which I'll talk about later. So here's a graphic description of DSM-5 section 3, the so-called alternative model that's beginning to catch on. And it's interesting that it's influenced by Kernberg's thinking. You can clearly see that. So criterion one, so first of all, this defines personality disorder as dysfunction in self and other functioning. Not just around symptoms, but around dysfunction in self-functioning and interpersonal functioning. So criterion A is self and other functioning, and criterion B is pathological personality traits. And this is criterion A. It defines self-functioning in terms of identity. You can see the influence of Kernberg. Experience of oneself as unique, clear boundaries, good self-esteem, accuracy of self-appraisal, and so forth. And then self-direction, that is pursuit of coherent and meaningful goals in life. And the interpersonal elements in terms of empathy for others and the ability to have intimate relations with other people, with friends and other people. So this is really introducing the person back into personality disorder, not just symptoms. Symptoms are very important, but also the development of the person himself or herself. It's accompanied, as I said, by severity. So you really are asked then to rate the level of severity of the personality disorder. And I'm going to argue with you in a few minutes that what's really important in planning treatment for these patients is not whether it's borderline or not, but how severe is it from relatively mild to extremely severe. And so I would be arguing that TFP, or any treatment for that matter, MBT, DBT, would have to be modified depending on the severity level of the dysfunction in terms of self and other functioning. So that's what I'm saying here, that the implication for assessment, you have to assess not only for personality disorder or not, but the level of severity. And the implication for treatment is that when you're dealing with personality disorder, it's not just a focus on symptoms, although that's important. Keep in mind, if the borderline patient is suicidal, we have to keep them alive, and we have ways of structuring the treatment to deal with that. But our overall focus is on self and other functioning, leading hopefully to some productive relationships and even work. And we tailor the treatment to the self and other functioning and the severity level of that. Now, this AMPD, the alternative model in DSM-5, is helpful, but it still has problems. It doesn't have a theoretical framework. It's purely descriptive. And it really doesn't describe why you need self-functioning as related to interpersonal functioning. And it provides no real direct link to how you're going to treat these patients. So that's where we think object relations theory can be helpful. As I said before, that the object relations theory model is a structural model, and it's based on basic structures, we think, that organize the behavior of the individual, including that basic structure of internalized representation of self and others. So we have a history of using Otto Kernberg's structural interview, which he described way back in 1983. It's a wonderful clinical interview. It's a combination of a classical psychiatric interview, but with focus on self-functioning or personality organization. But in my early work with Kernberg and senior psychiatrists at our hospital, I found that psychiatrists could not do this structural interview in a reliable way. So I couldn't use it for research because different interviewers would emphasize different things and they would come up with different scores. So that's the reason we devised the structured interview for personality organization, or the STIPO-R, which Inez and Raquel can tell you all about. It's worth trying it out. You probably should try it on a patient just to see if you like it, see if it gives you the kind of information you need. I personally think it's very helpful. Some people probably think it's too long, too involved, but I do think that you learn a lot and the patient potentially learns something about themselves. The heart of that structural interview, semi-structured interview, are ratings and information on these 5 different domains of functioning, what we call structures: identity formation, the quality of object relations or the quality of relationships with other people, the defensive style, the management of aggression, and moral functioning. And if you have a sense of those 5, you really have a good sense of how the patient functions in the interpersonal world. Now, in our minds, these 5 domains of functioning then coalesce into 4 levels of personality organization: high level or neurotic, and then levels of borderline organization. And this is a graphic representation. The top group is the neurotic level. I'm pointing with my finger and it doesn't do any good, right? Because you can't see it. But anyway, the neurotic level at the top, a high borderline, and mid to low borderline. So the typical neurotic personality organization would be like obsessive compulsive or hysterical. The high borderline would be avoidant and dependent, and some narcissists. And the middle to low include your borderline, and then of course, as it gets worse, your borderline with narcissistic features, and then the really severe are the borderline with narcissistic and antisocial features. So you can see as you go from the top, you have identity fusion, but you don't have aggression out of control, and you don't have moral functioning out of control. As you get to the bottom, you have severe problems in relating to others, object relations that are destructive and manipulative, with poor moral functioning, like in the antisocial, and a lot of aggression. So when you're relating to these patients at these different levels, you want to know as much as possible what you're getting into from the very first assessment. In my years of training psychiatric residents, I have never seen a more terrified resident. As the resident who at the beginning of the month had a new female patient who he thought was neurotic. And by the end of the month, he realized he had a borderline patient who was calling him on the weekends with panic and severe stress and suicidal impulses, and appearing in the emergency room once or twice each week. And I guess it might have been my inexperienced supervision at that time, but he should have known that, unfortunately, at the beginning of the month rather than at the last. So here I just try to describe at the left-hand column what we call the neurotic organization, high borderline, mid borderline, and low borderline, the description of each of those in terms of the classical categorical disorders. And then, of course, in the third column, the level of functioning that's in DSM-5 and the level of functioning and what it's called in ICD-11. So this is just to illustrate that the whole world now is going toward these various levels of dysfunction described in terms of self and other functioning. I think you probably use ICD-10 and ICD-11, right? We also do in the United States for insurance reasons. And then what that means is that the treatment objectives, the prognosis, and the treatment frame must be very different in TFP given the severity level of the patient. And I think it's probably obvious that when we go from a neurotic patient in TFP, the prognosis is excellent, and there's less need for a clearly specified treatment contract. But as you go across to mid and low level borderline, you have to have a much more specific treatment frame with, right from the beginning, notions of what you're going to do and what you expect the patient to do if the patient becomes suicidal or has impulses to hurt other people and so forth. And we try to specify that right from the beginning. It also means that from our point of view, the transference themes and the countertransference themes are very different depending on this levels of severity. To put it very simply, the countertransference with a neurotic patient, you feel like the patient respects you as an authority, is coming to you for help, recognizes they need help, and they appreciate your doctorly role in helping them get better. Whereas with a low level or mid-level borderline, you often feel uncomfortable. You feel driven to do something to try to control them. And as it gets into low level, you feel the need to protect yourself from the invasion of projections that the patient is putting on to you. These also call for, we think, more consultation with your colleagues, because the onslaught of the projections can be very difficult. Now, all this expansion of TFP from what used to be just around borderline to now all the levels of personality dysfunction is captured beautifully in this book by Eve Callagore, Otto, myself, and Frank Yeomans. If there's one book at this point from our group that you might use in training, I think it would be this one. And I'm not trying to sell it. I'd be most happy to send Raquel and Inez a copy. It might help in your training. So what's happened to our research? By the way, time-wise, I have about 10 more minutes. Is that all right? Is that going to give time for discussion?
Yes, but it's been very, very good for us, John. Please go ahead.
Okay.
Feel comfortable. Your experience in this area is very, very profound and very nice for us. Please feel comfortable to go.
Okay, thank you. You're very gracious. Thank you. So what about our research? Everything I'm telling you, you might believe me. Of course, I might be exaggerating our effectiveness. So let's talk about the research. There's two basic questions in the research efforts. One is, does it work? Does our treatment work? When you compare our treatment to other treatments, is it reducing symptoms? Is it helping these patients function better? And then in some ways, if you know that it works, at least for most of the cases, not all of them, then how does it work? What are the what's called the mechanisms of change? How does it work? Because if we can understand how it works, we can make our treatment more efficient and more effective. So first of all, we did a randomized clinical trial that was published in the American Journal of Psychiatry in 2007. And we found that when we compared it to DBT of Marsha Linehan and to a structured supportive dynamic treatment, that all three treatments made positive changes for most of the patients. To me, what that means is that if you give coherent, structured, supportive approach to these patients, like Inez and Raquel are doing in their service delivery in your hospital, a lot of these patients are going to get better, at least at the symptom level. Getting them to have friendships, to have intimacy, and to work, I think, is another thing. But at the symptom level, you can get them better. Our TFP, interestingly enough, was superior to the other two, despite the low number of patients, in reducing anger and impulsivity and verbal anger. Now, many people criticize Kernberg for emphasizing aggression in his theory. But I think that anger and aggression, in other words, negative affect, is a cardinal symptom of these borderline patients. And it has a lot to do with the way they disturb their friendships, they disturb their family relations, and it disturbs their work function. And so reducing anger and trying to increase some positive affect is a very important outcome. Secondly, then, we were faced with the idea, it's one thing to show that Kernberg's treatment works in New York where Kernberg lives, right? But what about, could we transfer this treatment to Europe? And we have colleagues in Munich, Germany, and Vienna, Austria. And again, we did a study there comparing TFP to treatment as usual in the community, paid for by the German-speaking insurance companies, of therapists in the control condition who were used to and had a history of treating borderline patients. And we found that, in fact, TFP was superior in many ways in terms of reducing suicide, symptoms, and in improving functioning. So we really think there is some added benefit of TFP beyond just the structure and the support, which are very important in all treatments. So then the next question is, if it works, how does it work? Our theory suggests that the therapist is focusing on the dominant object relationships between the patient and the therapist, and between the patient and their contemporary colleagues or friends in their environment. As we explore those relationships and explore the deficits in those relationships, we posit that those things change, that the representations of self and other, at least in relationship with the therapist, begin to change. And then, if the treatment really works, the representations of relationships are going to change with people in the environment of the patient, not just with the therapist. Because if it's only with the therapist, it's not going to affect their daily lives. And then we hope that leads to long-term social and occupational changes in their lives. So how do we go after that? So remember, our central notion here is the representation of self, representation of other with related affect. We've done 3 research approaches to looking at this central construct before you: reflective functioning and narrative coherence, a diary study, which the fancy word for it is ecological momentary assessment, and an fMRI study of 10 patients in TFP for 1 year, fMRI before and after 1 year of treatment. So first of all, reflective functioning. Peter Fonagy from the University College of London is well known for saying, emphasizing the construct of mentalization. And according to him, mentalization is the developmental capacity to evoke and reflect on one's experience and to make inferences about the behavior as emitted by oneself and other people. This has been operationalized and measured as reflective functioning, the capacity to reflect on experience between self and others in terms of emotions, motivation, feelings, and thoughts. And so we use the adult attachment interview pre and post 1 year of TFP in the 2 studies I told you about, the study in New York and the study in Vienna and Munich. So it's a combined N of, I think, almost 150 patients. And basically, we found that TFP, in fact, significantly improved reflective functioning, the ability of the patient to not act. Borderlines act, they don't think. But we got them to think in more coherent ways about their feelings and their interactions with other people. This change did not occur in DBT, in the control condition in Germany and Austria. It did not occur. Now that's still interesting, very interesting, because if you ask Marcia Linehan, who's in charge of DBT, if you said to her, well, Marcia, your DBT changes symptoms, but it doesn't change reflective functioning, she would say, I don't care. What I really care about is symptoms and behavior. Well, we don't totally agree with her. We think that the well-being, the satisfaction, and maybe the long-term outcome of patients who both reduce their symptoms but also improve their reflective functioning are going to be better off. But that still needs more research, that's for sure. Our second approach was influenced by the fact that we live in a computer technology world. So most of our patients, including the adolescents, have cell phones. In fact, they're addicted to their cell phones, right? My 12-year-old granddaughter just got her first cell phone, and she's excited like crazy. I think it's a good and a bad thing, but at any rate, so what we're doing is what's called ecological momentary assessment. We put an app on our patient's cell phone, and under controlled conditions, we ask them to report almost in live time about their interactions with other people. So what appears on their cell phone at the end of a day for 14 days in a row, at the beginning, middle, and end of their treatment are these two grids. And they indicate on the grid how they behaved with somebody else, either dominant or submissive, either cold or warm and agreeable. And they simply have to mark on the grid where they saw themselves behaving and where they saw the other person behaving. And then on the other grid, we asked them about the affect. What feelings did they experience and what did they think the other person was experiencing? So this is a computerized, operationalized view of their dominant object relationship, right? What's going on as they relate to other people in their lives. We also ask them about with their therapist, how do they perceive themselves? How do they perceive others? And what affect are you experiencing? We haven't analyzed the data yet. We've only done selected individuals. But we do know, and of course, we'll analyze all this data. But you know, it's like introducing an observing ego, what the analysts would call an observing ego, into the lives of these patients. It makes them more reflective of what's going on throughout the treatment in their daily lives. And over 18 months in several selected cases that we've analyzed so far, we find that patients are beginning to experience more positive, warm as opposed to cold and negative interactions in daily life, and that their interactions become healthier. I don't have time to describe that, but healthier with the therapist first. And then by 18 months, that begins to happen in their daily lives. So far, this data is encouraging. I sometimes wonder if the EMA, having the cell phone reporting, is actually a treatment in itself. It'll be interesting to see in the future how it might become an ancillary therapist in their cell phone. And then the final thing I just want to mention, it's a real pilot study, but we know from the literature that borderline patients display greater mood variability in response to stress. They really don't handle stress very well. And they're very prone to anger and disillusionment in social rejection and abandonment. They see social rejection and abandonment everywhere. And so affective instability has been associated with reduced top-down prefrontal activity and enhanced amygdala and insula activity when faced with emotional stimuli. So we put together what's called a go, no-go task that we give the patients while they're in the scanner. So you can imagine the patient lying in the scanner, looking up at a screen where they can see stimuli, and we ask them to do tasks while they're in the scanner. And we do that before 1 year of TFP and after 1 year. And what we find is, in fact, at the psychological level, we find them reporting more control of affective stimuli, more emotional control, and they've had some symptom improvement during this 1 year. At the brain level, we do in fact find decreased amygdala activity and increased prefrontal and cingulate activity. So that putting this together, it would suggest that the treatment itself, although we didn't have a control condition, we couldn't afford that, but the treatment itself is beginning to improve affective regulation by these mechanisms at the brain level. So I think that I'm not even sure, well, I'll give you the summary. I think we obviously focus on dominant object relationships between both the patient and the therapist and the patient and other people in his or her environment. We see changes in reflective functioning. We see changes, at least at the beginning, in daily environment, in relationships with other people by the EMA. And we do see changes in brain regulatory mechanisms, suggesting that TFP is enhancing emotion regulation. So in conclusion, and I hate to tell you, years go by when you're having fun, but we've been at this now for 40 years. But I think object relation theory is validated by growing function in the psychiatric world in our diagnostic systems on self and other functioning. I think the emphasis must be on severity, not just what kind of disorder. We've shown, I think, that you can reliably assess concepts, analytic concepts such as object relations and object relations theory. The impact of TFP can be measured in symptom change, but also in mental functioning changes, and this can be transported to places like Munich and Vienna. And one day, I hope in Sao Paulo, Brazil. So if you want additional information, you can go to several of our websites, borderlinedisorders.com and ISTFP.org. ISTFP stands for the International Society of Transference Focused Psychotherapy. And that's all for now. So do we have a little time for some discussion?
Yes, yes, we do. Let me just get the chat here. It's not working very well. Well, Professor Clarkin, I'm enchanted by your talk, so you've been working on that on 40 years, and you show to clinicians in psychiatry how important it is, first of all, to assess well personality disorders from the right beginning of our work. And it's very impressive, the development you had in terms of acknowledging the interaction between biological vulnerability and experience, the gene environment influence, the link you did with neuroscience, fMRI assessments, and also measuring outcomes and the process. I mean, there is so much to learn for psychiatrists, from the way you see the patient and functioning and all the symptoms and measuring things. I was really very impressed. Well, I want the girls to talk more about your work. I just have one question. How do you interact with clinicians, clinicians in psychiatry? Do you work together? What sort of interaction you have to clinical psychiatrists, or you take all the responsibility for the PD patients? How is that?
So you mean when we do the research, do we interact with psychiatrists in the clinic? Is that what you mean?
No, in routine clinical practice, how you do this interaction of TFP and clinical psychiatry?
Well, in our first of all, we do not have a clinic ourselves. We are able to organize our research with clinicians out in the community. So a lot of the research that I've described to you, these were patients treated in psychiatrists' offices throughout New York City, in their offices. And I should add, it's interesting that I forgot about this. These, in our research, our patients also have medications. So one of the ways we interact with psychiatry is also we have people who are not TFP therapists who see these patients briefly when needed for medication. I should not have left that out. I think that we do not see, how to put this, when a borderline patient comes to us from the services or the ER or wherever, typically we find borderline patients with multiple drugs, multiple medications. We try to reduce the number of medications and the dosage as the patient gets better. But we respect the medication and we keep it going and slowly reduce it. And our clinical understanding of that is that these medications are helpful often at the beginning, but their effectiveness tends to wear off with time. So that the reason the APA says that the major focus of treatment is psychotherapy is because we really don't have a drug for borderline personality disorder. It's just too complicated. So we do have medications for some of the symptoms, but not really for the personality organization itself. Yeah.
Perfect. Thank you very much. So I will transfer to either Inês or Raquel. Would you like to make any comments?
Maybe I'd like to make just a question.
Sure.
We are in a medical school, and I would like you to tell us how's your experience using TFP in a training program, like we have psychiatry residents. How is your experience with that, using TFP?
Yes. Our medical school and our Department of Psychiatry is, I think, somewhat unique in psychiatry across the United States. We are known as a medical school and a residency that will teach you about biological psychiatry, but we also have a reputation for teaching psychodynamic, psychoanalytic therapies and so forth. So we tend to attract at least half of the residents who are interested in psychotherapy and psychodynamic treatment beyond just biological psychiatry. So TFP is well accepted in our training program of residents. So residents get seminars in TFP and psychodynamic and object relations theory, especially in their second, but mainly in their third year when they're doing outpatient psychotherapy. Often they take one or two patients under supervision with TFP, and then in the fourth year they can do an elective with us. So I would say it's very well accepted by half the residency classes who are very interested in psychodynamic psychiatry. The other half, I think, find real help from our orientation, not so much from the psychodynamic aspects, but from the structuring, the contract setting, the way we emphasize assessment and structure. I think that's helpful to all psychiatrists. whether they're psychoanalytically oriented or not. We have even found in the medical residencies, we have one TFP person who was just a practitioner of medicine, general medicine, before he went into psychiatry. And he teaches a course in personality disorder to the medical residents at Columbia. And even the medical residents, general medicine, find it very helpful in terms of our contract setting to deal with their medical patients who act like borderline patients getting their medical care. Yeah. Sorry, Inez, you had another comment.
No, that's fair. I have lots of questions, but I think I'll let my colleagues ask some too. Álvaro, thank you.
I will leave you for the last word. Álvaro Ancona wants to make a question.
Surely.
No, you are mute.
Dear Professor, always a pleasure to hear from you. I had this opportunity many times also at the ISSPD meetings, but it's always challenging. And I think I would have thousands of questions, but I would like to ask you about your comment on Marsha's Linehan comment. Because I think I coordinate one of the groups who work with borderline patients here at the department. We work in a mixing of psychiatric and psychodynamic approach. And the residents come with us, and it's more or less, all the same thing everywhere. Right. Trying to see wider, as you said. I'd like to ask you something that I think it's very important. Many times, all the techniques centered in the psychodynamic approach, there is a worry or concern that these techniques are more expensive. We spend more time forming people, training people. We spend more time seeing patients. And the answer, the question you posed about Marsh's comment, I would like to say that in my opinion, and I would like to hear from you if you have the same idea, that there is this study published in 2006 by Chiesa and Fonagy, for instance, just one of them, showing that in the DBT, you have a quicker response in some of the symptoms. But whenever you use any of the psychodynamics techniques, you have an improvement in the symptoms for much longer than when you use techniques that sometimes give you a quicker answer. So I would like to hear from you, what is your opinion about this cost effectiveness question?
Yes, Alvaro, it's a very sophisticated question. And at this point, I think we don't have enough data on that. And I think it's a very serious concern for all of us. Let me try to answer it. First of all, in our current treatment study that's ongoing now, we are getting data on first of all, we're treating borderline patients for 18 months in this study, but we're getting data on their progress every 3 months. So we can draw a regression line showing at every 3 months, is this patient getting better or getting worse? And in what areas are they getting better in terms of symptoms, in terms of functioning, etc.? And I think that we need that kind of data across DBT, MBT, TFP. And yes, I would assume that the data is accurate, that with the focus on particular symptoms, especially suicidal behavior that Marsha does, she probably gets a faster response. And in fact, I could imagine in a service delivery system where you have, keep in mind again, the severity level. See, all those studies did not measure the severity of the borderline. So I think all those studies have to be done with more measurement across time with severity level. But I would guess that Marshall Linehan and the very structured DBT approach has a bigger change faster than a psychodynamic treatment. I would think that's probably true. In fact, it may be that in some systems of care, if you have the resources, it might be better to use DBT first as an introduction to TFP. That would be one thing that I would think about. Because we get many patients who have had DBT, and the DBT has helped them, but they still are leading lives that are really empty and not satisfying, and we try to take them further. So I hope my answer is clear. I think we need more data. I respect Marshall Linehan and her structured approach very much. I think we do better. A father of a borderline patient told me the other day, he said, I want my daughter to have TFP. She's had a lot of DBT. She could teach DBT. She knows it so well, but she still is suicidal and not doing well. I think that's the kind of patient, because, you know, some of the DBT patients, some of them improve dramatically. Others say, I learned the skills, but they admit they don't use them. So I think the TFP hits more at motivation and the willingness to live a better life than DBT. But we shall see. A lot more work needs to be done. Thank you, Alvaro.
Thank you very much. Always a pleasure to meet you.
Caio, try to be very short, because there are many people willing to ask questions to John.
Sure, I'll be very brief. I just would like, congratulations on your presentation first, and I would like to know if you could talk briefly about training in TFP, and how is it different from training in other kinds of psychotherapy?
Sure, thank you. First of all, I would encourage you to contact my colleague Frank Yeomans. And if Inez, I think Inez has his email and so forth. And so he's the director of our training program. Within a Zoom world, we train people all over. And the guts of the training is basically doing the seminars, reading the manuals, and then getting supervision on actual cases. And I think that's probably a lot like training in other psychotherapies. The real action is after you've read the manuals and got the cognitive skills to then do it with actual patients.
Let me just tell you, Caio, just a moment. Caio, we started Institute of TFP in Brazil. Me and Raquel and our colleagues that are here from Rio Grande do Sul. So, and I think we'll have, we're studying, we're learning to do it, trying to learn to do it. And someday maybe we'll have a group for first training here in Brazil. But well, we'll give you the address, the site too.
Great, great.
But you can follow us on Instagram.
Right.
Felipe, try to be brief also, please. I'm giving more, asking people who raised their hands to put in the line. Felipe, go ahead.
Okay, thank you.
Please.
I'm happy to be here. And Mr. Clarkin, you are a genius. not only as scientist, but as teacher as well, and Portuguese speaker, because you was very, very clear for us. And I have a question, how symptoms related to gender issues are treated with this technique, the TFP, and how can we research gender aspects in borderline personality disorder? Because I think it would have a lot of bias in researching it, because it's tricky studying this kind of phenomena, you know. So I'd like you to tell us about it.
Yes,
please.
absolutely. I have to be brief, but first of all, since Marsha Linehan, most of the research, the treatment research, has been on female borderlines. And that's unfortunate. That's another real gap in our information. Why? I don't know why she focused on females. It's very clear why we do, because in New York, at least, female borderlines go to the emergency room and to the hospital. They want treatment. Male borderlines, at least in New York, go to addiction centers and go to VA hospitals because many of them have been in the military. So you hit on a very important, I think, biologically based phenomena that and this is an oversimplification, but female borderlines tend to hurt themselves. Male borderlines tend to hurt themselves and other people. So they get in trouble with the law, they abuse drugs more. It's more I guess, a testosterone-based phenomena. So one of the reasons we haven't done it with males is because we don't have them. They don't come to our hospital. But you raise an extremely important point. We should the research must expand to males.
John, males become politicians.
Right. Yes, I think that's true. We had a president in the near past that is a poster child for what I was calling what Otto Kernberg has called malignant narcissism. You know, where
please.
Yeah, well,
we know
I
that
won't
now.
comment on our president. Don't need to. Luciano, be brief, please.
Thank you. Okay. Hi, John and others, colleagues. I'm Luciano Luiz. I'm from Porto Alegre, south of Brazil. And it's a pleasure to hear you again. It's a great talk. Thank you so much. But I'm finishing my doctorate degree working on the type OR, and we already have the first validated evidence of the Brazilian versions, and we have good notice. We can anticipate that so far we found a good internal constants beside a good temporal stability and interrate stability, reliability. We'll soon share these results and the next as soon as they are finalized. But I would like to ask you how this type OR has been used in the research setting around the world, so that we can be inspired to continue researching and working here in line with what is being done, and so that we can contribute with more data and researches. I know this may be a little of a broad question, but if you could give us a quick overview of your impressions of how we can best use this type of OR in future research, and if possible, you talk a bit about the other use of the instruments in both clinical and educational settings, that would be great. Thank you. Sorry for my English is not so good.
No. Luciano, I understood quite well. First of all, if you email me, I would provide you with names and emails of key people who are doing research on the STIPO-R. So people who come to mind are Suzanne Herz in Munich, Germany, who's done a lot of work with the STIPO-R, Emanuele Preti in Milan, Italy, and my colleague Barry Stern in New York. And I think that's, they can help you in an extended way more than I can with just a few words here. I think the STIPO-R can be very useful in training residents in training. Not that they're going to do it on every patient throughout their career, but it gives them an internal sense of how to evaluate personality pathology. I think that the STIPO-R can also be used to help show that the information from the STIPO-R is more predictive, and it provides predictive validity in patients across time. But that's just a minor example. I think the most important thing, and I think your question is an excellent one, research should be fun and it should be done with other people. And the best I can do is get you into contact with other people that you can enjoy meeting them and talk to them about research design and research questions. Wonderful question, Luciano.
What I'm gonna ask people, thank you, Luciano, thank John, some minutes more, extra minutes. I would like Raquel to say some words, and the mother of the service, Dr. Julieta Freitas, to end the talk. She can speak Portuguese if she wishes, no problem.
Julieta.
Raquel, try to be brief also, everybody, just because of time.
Não, eu queria só agradecer a presença de todos.
Deixa eu falar.
Julieta, que é primeiro, eu ia fechar com você.
Não,
Você
de jeito nenhum.
fecha, Julieta.
Eu queria somente, Jair, que você transmitisse a ele nossos agradecimentos pela brilhante palestra. Obrigada.
Pode deixar. Legal, Julieta. Legal que você está aí e você é a mãe do serviço.
Uhum.
Raquel, no, Julieta, Dr. Julieta is the mother of the service, so that's why I'm saying thank you to her for all the work she did all over these years. Raquel?
Eu queria agradecer a presença de todos, né, e essa audiência aí que nos acompanhou até o final, excelente, né? E mais de 100 pessoas estiveram aqui hoje. And thank you for you, John, for your brilliant class today, and look forward to continuing our partnership to help our patients live better lives. Thank you very much.
Thank you, Raquel. And thank you, everybody. It was a pleasure.
Yeah, I give you the final word, John. Really.
Oh, the final word. The final word is, I want to meet you people in person.
Yes. But anyway, really thank you for this brilliant conference. You know, it's a privilege of our department to have your time, your skills, and, you know, your openness to teach. And it was really very clear. As I said, you know, it looked like Portuguese, you know, you talked slowly and explaining so well the concept. So we are really, thank you. We wish to thank you for all your effort to communicate and to bring this very important and special field where we have to develop a lot, and you show the ways of doing that. So I give you now the closing remarks to you, John. Thank you so much.
Thank you. It was a pleasure talking to all of you. The questions were wonderful. And remember, Dr. Mari, you promised me a Portuguese dinner in Sao Paulo. I'm going to take you up on that.
Yes, in a very nice place, hopefully, with a very good wine. Thank you so much, John. Thank you, everybody.
Thank you,
I'm sorry
Professor.
we were unable to give the, to everybody to have all these questions, a list of lots of questions. But anyway, it was a pleasure to have him talking to us, because it was so much very good information that, we wanted to have this information. I think it was very useful. Thanks so much. Have a nice week. John, see you soon.